Welcome. In this video, we'll be going over observational studies and other high-yield topics such as odds ratio, relative risk, and others. So let's first talk about what observational studies are. They are exactly what they sound like. These are a group of studies in which the person doing the study is observing something over a specific point in time, time being the key word. Now, there's a multitude of different types of observational studies, some of which will be covered for completeness sake at the end of this video. But there are three primarily observational studies that are tested and compared to one another. The way that I like to remember these three is by drawing a diagram similar to this one, in which the arrows represent time. The arrow over here to the left going backwards represents the past. The arrows over here to the right going forward represents the future. And the arrow going down the middle represents the now, or the present. So let's first talk about the past. Typically, these studies revolve around case-control studies, and case-control studies are exactly what they sound like. This is a case group versus a control group, or a placebo group. Now, what do they look at? Case-control studies looks at a group of people with the disease, and then they go back in time and they look at the associated risk factors. And this group is compared to the placebo group or the control group, which does not have the disease. So case control here starts at the present, like most studies do. Starts at the present. We go back in time and we look at what associated risk factors may have contributed to this study. Now, case control, notice how the O and the R are highlighted. This is to help remind you that this is useful for calculating odds ratio, which we will talk about in the upcoming slides. Case control is typically compared to cohort studies, which we can see is by the right arrow or the future arrow. What does this do? Now, similar to case control studies, cohort studies also has a cohort group, which compares to a placebo or a control group. Differently than case control studies, though, this group looks at a group of people with certain risks and see if they develop the disease. So again, starting in the present or starting in the now, we look at people with risk factors and we see in the future or over a certain set amount of time to see if they develop a disease. This is compared to control studies or case control studies, in which you start with the disease and you look back in time and see if you develop the risk factors. With cohort studies, you start with the risk factors and you look to see if you develop with the disease. Now, cohort studies can be a little bit more tedious in the fact that this can also be retrospective or prospective. The way that I like to remember this is retrospective. I always think of like the 70s or back in time. So this, I know I actually can go back in time and then look to see what happens. With prospective, just like in baseball, you have different types of prospects, or back in the day for weddings or for engagements, you can have like multiple prospects. This goes into the future. Prospect baseball players will be in the MLB in the future. So prospect, we're going to go ahead in time. Retrospective, we're going to go backward in time. Prospective cohort studies are your typical well-defined cohort studies, pretty much what we just went over. But what likes to be compared on your exams is case control studies compared to retrospective cohort studies. Now, why? What's the big takeaway? Case control studies, like I've already emphasized, start with the disease, they go back in time, and they look at risk factors. Retrospective cohort studies, on the other hand, start in the past. They look at risk factors, they follow them up into the present, and they see if they develop the disease. The difference is what you start with. With case control studies, I'll emphasize again, begin with the disease. Cohort studies or retrospective cohort studies, you begin with risk factors. And that's a big takeaway point. Now, notice how the R and the T are highlighted for cohort study. This helps to emphasize or to show you that this is used to calculate relative risk, which we'll talk about briefly. For completeness sake, we can also use cohort studies to help calculate incidence, which will be talked about in upcoming videos. But I just want to include here just for your understanding. And then, of course, the last one we'll talk about is the cross-sectional studies, which is looking at the now or the present. This shows what is happening now or in the present, and this is very helpful for monitoring prevalence. Prevalence is usually compared to incidence, and we will talk about it in a future or upcoming videos. But my big takeaway point with cross-sectional is it is a snapshot. It is a picture about what is taking place at this moment of time. It is a study that will be done today. Okay? The big takeaway is case control versus cohort study for this, especially understanding that case control begins with the disease. You go back in time and then you look at the associated risk factors. Cohort study begins with the risk factors and you see if they develop the disease. So let's first now move on and talk about case control studies a little bit further and talk about odds ratio. So remember, with odds ratio, we are using case control studies. Case control studies, again, are people with the disease, and then we assess for risks. So an easy mnemonic in order to remember this that is typically taught is you take a case to the OR, very medical-based mnemonic. Case, control studies, OR for odds ratio. That's how you can relate those two together. Now, when we're talking about what odds ratio is, we typically have to start by drawing our 2x2 table. Okay? 2 boxes by 2 boxes for a total of 4 boxes. Typically, I like to put the disease up top and, of course, the risk or the exposure on the left side here. And then I'll fill in yes, no, yes, no. So we see here, this box means that I have the disease and I have had the associated risk exposure, where this box with the X says that I do not have the disease and I have not been exposed. Once you understand this, this will help to formulate the rest of our problems moving forward. I then put in A, B, C, and D. Now, what exactly is odds ratio? Odds ratio, in a simplistic term, is equal to people with the disease compared to people without a disease. Now, it's an odds ratio. I am looking from the present and I'm going back in time. It's not very specific. I cannot get a lot of information out of it. For that reason, we typically can generalize stuff from odds ratio. But the big takeaway is that we're looking at people with the disease, so this box right here, these boxes, compared to people without the disease, or these boxes right here. If you understand this general concept, you'll understand the formula. The formula for odds ratio is going to be A over C, or people with the disease, divided by B over D. If you were to cross multiply, you would get A times C over B times D. Oh, sorry. If you were to cross multiply, you would get A times D over B times C. But understanding this general concept right here will help you to get these questions right. Odds ratios, people with disease over people without disease. Now, sometimes how they'll ask this is they'll ask you to interpret the odds ratio. So how do we exactly do that? So odds ratio can be greater than 1, equal to 1, or less than 1. Let's start with equal to 1. You'll find a general rule of thumb in statistics is when that things are equal to 1, there is typically no difference or no significance. This is true for upcoming relative risk as well as when we talk about confidence intervals. Now, it's important to know that with odds ratio, we cannot make a firm statement, right? If the odds of the exposure are greater than the control, such as OR, or odds ratio, is greater than 1, then the odds of the exposure are greater in the cases. Essentially, what this is meaning is that people with the disease are probably more likely associated with people with the risk. The numerator here will have a higher value. When the odds ratio is less than 1, the odds of exposure are greater in the control group, or the people without the disease. This pretty much means that the risk is probably not associated with the disease. So for example, if we have an odds ratio equal to 8, and we're talking about smoking and lung cancer, this would mean that people with lung cancer, or with the disease, are 8 times more likely to have a history of smoking. They are 8 times more likely to have done the risk. That does not generally mean that the risk equals the disease. It is implying that it might. And for completeness sake, I wanted to put this for rare diseases. Sometimes we can calculate odds ratio and relative risk. We'll talk about relative risk in the upcoming slide, But it is important to know that for rare diseases, since we do not have enough numerical input or enough studies, we can pretty much mesh these two together. Now let's do a practice question. You guys can pause the video and do this question yourself. But we have a case control study investigates the association between antibiotic use and the development of C. diff. The data are as follows. Here's our data, and it's asking what is the odds ratio. So it's nice. The data is already given in kind of like a table-like format. We can see that up here is the disease, people with C. diff and people without C. diff. And of course, here's our risk or our association of error exposure, right? On the left side here. This is people with and people without. So it's already appropriately set up, just like our 4x4 table. So we can fill this table in as we know that this is yes, this is no, this is yes, this is no. Very similarly, you just want to make sure that when you get a table on the exam, that it is set up appropriately to the table that you're used to creating. Okay, sometimes they do not always do that. So here's 80, 20, 40, 60. Now, if you remember, our odds ratio is risk our odds ratio is disease divided by no disease. So it will be this line divided by this line. Okay? Remember, this is an odd, so it's the likelihood of something happening, so it's not as specific. So we can only use generalized terms. So we typically do not use the summation of people with the disease. This will be compared to relative risk shortly. So this will be 80 over 20, which is equal to 4, divided by 40 over 60, which is equal to 0.67. 4 divided by 0.67 is about 6. So remember, using our odds ratio, you are 6 times more likely to have it in your cases portion. What does that mean? That means that people with C. diff are 6 times more likely to have had antibiotics exposure. I cannot make that definitive assessment that people with C. diff had antibiotic exposure. It is 6 times more likely that they would have had antibiotic exposure. And that is odds ratio. Continuing forth, let's talk about relative risk. When we're talking about relative risk, we're typically used in cohort studies, as we've already gone over. The big takeaway here is that this is people with risk, and then you assess for the disease. So what do you think relative risk is? Relative risk is equal to people with the risk divided by people without the risk. Just like odds ratio is people with the disease divided by people without the disease. So I get my little 4x4 table. Here's my disease. Here's my risk exposure. I put, yes, I have the disease. No, I do not have the disease. Yes, I have the exposure. No, I do not have the exposure. I could put A and B and C and D in again, and that'll help me remember what my equation is. So what do you think relative risk is? Relative risk is moving forward in time. I'm starting at the present, and I'm following it over some sort of time. This is typically for prospective cohort studies. So it's going to be people with the risk divided by people without the risk, correct? So essentially, it'll be A over A plus B, the total here, because I can be more definitive in this. So I use more values, more numbers, over C plus D. And that equates to our relative risk formula, okay? So it's people with the risk over people without a risk. So I think the best way to describe this is to go over briefly an example. So if 21% of smokers develop lung cancer versus 1% of non-smokers, what is the relative risk? The relative risk is going to be people with the risk, which is smoking, and then they develop lung cancer, divided by people without the risk, or non-smokers. So basically it's 21 divided by 1, and it's going to be 21. That is my relative risk. What exactly does this mean? So just like with odds ratio, we can depict what relative risk is. Relative risk is going to be when it's equal to 1, it's typically non-significant, no association between the risk and the disease. This is a common theme, again, that we see throughout statistics. When the relative risk is greater than 1, just like in this case, we can be a little bit more definitive than odds ratio. We can say when relative risk is greater than 1, there is an increased chance of the disease due to the risk. And the example that was typically given is the example here. So what would this mean, a relative risk of 21? Well, that would mean that there's a 21 times greater chance of getting lung cancer if I smoke. Where if the relative risk is less than 1, then there's less of an association with the risk than with the disease. Classic example there would be exercising. Typically, if you exercise, you do not get the disease. So we would expect the relative risk to be less than 1. And again, I'll erase this for now. But just knowing that for rare diseases, we have odds ratio is typically equal to relative risk. So again, let's solidify this with a practice question. So pause the video, take your time to do this one, and then we'll go over this together. So we have a cohort study that investigates the relationship between smoking and bladder cancer. Smoking is my risk, bladder cancer is my disease, and the data is collected. Here's my data. They say the relative risk of developing bladder cancer for smokers compared to non-smokers is calculated. What does this mean? What does this relative risk mean? Sometimes on your board exams, or on your exams in general, this will be the way that the question is phrased. So again, here's my disease, here's my risk, here's yes, here's no, here's yes, here's no. So it's already put appropriately for me. So if I need to remember, relative risk is going to be people with the risk, so people who smoke divided by people who don't. And it is going to be the cumulative sum. It is going to be over the total because we get a little bit better information here. So it's going to be 30 divided by 300 divided by people who do not smoke, or the no risk, 10 divided by 300. So this, when you put it in your calculator, comes out to 3. Okay? So let's look at the answers. What exactly does 3 mean? If my relative risk is 3, that means I have 3 times the likelihood of developing bladder cancer if I smoke, compared to people who do not smoke. So the answer choice here would be B. Smokers are 3 times more likely to develop bladder cancer than non-smokers. Now moving forward, we'll talk briefly about relative risk reduction. What exactly is relative risk reduction? So relative risk reduction is the relative decrease in the risk of an adverse event in the unexposed group compared to the exposed group. So whenever you see the term reduction in statistics, that means we are minusing something. So again, we can draw out our little diagram. We can say yes, we can say no, we can say yes, we can say no. We can put A, B, C, and D in it. So what exactly is relative risk reduction? Relative risk reduction is always going to be compared to an unexposed group to an exposed group. Now there's 2 ways that we can remember this. You can either remember as CER minus EER over CER, or 1 minus relative risk. What exactly is CER minus EER over CER? That just sounds like a lot of just letters. So CER is going to be the control group minus the experimental or the exposed group divided by the control group again. This is literally the definition. Understanding the definitions will help to remind you what the equations are. We are taking the unexposed or the control group, we're minusing it from the exposed group, and we're dividing that all by the control group. Or, which is more typically commonly taught, is 1 minus relative risk. That 1 value is your unexposed group. The relative risk is obviously your exposed group or your at-risk group. So let's calculate this both ways using an example. If we have 2% of people who receive a flu shot or receive the exposure develop the flu, while 8% of the unvaccinated or the non-exposed patients develop the flu, what would be the relative risk reduction in this case? Well, let's calculate it the first way, 1 minus relative risk. So I would need to calculate relative risk first. Well, we know relative risk is just risk divided by no risk, or 2 divided by 8. So of course, when you do 2 divided by 8, you get 0.25. 1 minus 0.25 is going to be equal to 0.75, or 75%. That means my relative risk reduction is around 75%. I have 75% that the risk is not affected with the unexposed group compared to the exposed group. The other way that we can calculate this is using our known definition, our control minus our exposed over our control. So what's the control group? The control group is the group that's not exposed. It's going to be 8 minus 2 minus the exposed group over 8. Well, that just equals to 6 over 8, which is also equal to 0.75. Either way, you get the exact same answer. I like to remember as control minus exposed over control because it helps to remind me exactly what I'm calculating. Now, sometimes on board exams, or on exams in general, they'll try to confuse you and they'll try to ask you different ways. These are some other ways that they can ask you. The big takeaway here is to notice how each question is comparing the control group with a risk involved. What is the relative decrease in risk? What is the proportion of events prevented by relative at the baseline risk? Baseline risk just means control or placebo. In some way, shape, or form, I'm comparing the risk group and the control group. So here's another practice question. I'll give you time to read it. But we have a clinical trial of a new antihypertensive drug that shows a relative risk of developing heart disease in the treated group to be 0.67 compared to the control group of 1. What does this result tell you about? Well, I know that this is asking about relative risk reduction because this is telling me that here's a control group or the placebo group, and I'm comparing this to the exposed group. So what is the difference? What does this tell you about the drug? So all this is asking you is, what is the relative risk reduction? And what exactly does that mean? So what is relative risk reduction? Well, 1 minus relative risk. They already gave you the relative risk to be 0.67. So the relative risk reduction is just 1, because that's our control. Our control group is 1 minus 0.67. And I could do this either way. This is control minus exposure divided by control, right? That's my other equation. Either way, I get the exact same answer, 0.33 or 33%. So I can pretty much get rid of all the answer choices that do not say 33% in it, which is C or D. Now, remember, use the name to your advantage, relative risk reduction. What is the reduction likelihood of it being exposed to the risk? So the only logical answer choice using that term would be B. The drug reduces the risk of heart disease by 33%. Hopefully that makes sense. We'll keep going next with attributable risk. Attributable risk is defined as the difference in risk between exposed and unexposed groups. Sometimes I like to call it attributable risk reduction. You do not have to. This is not the appropriate term. It just helps me to remember that this is something subtracting something else. Reduction always means the minus. So what exactly do we contribute to just the risk? So I'm going to draw out my little boxes here. I put yes and I put no. I put A and B and C and D. So what exactly is attributable risk? Attributable risk is the difference or the subtraction between the exposed, this would be my exposure or my risk up here, minus my unexposed. So what does that come out to? That is A over A plus B minus C over C plus D. How much of this is attributable to just the risk by itself? So attributable risk, I like to think of it as exposed minus unexposed. So let's do an example. Here's a very similar example to the one that you've just recently seen. So if we have 21% of smokers develop lung cancer versus only 1% of smokers, what is the attributable risk? Remember, the attributable risk is people with the exposure, aka smoking in this case. So it's going to be 21% minus 1%. So the attributable risk is going to be 20%. Hopefully that makes sense. This is another way that they can ask it. This is for your purposes, okay? Notice that everything is always being assessed with different types of exposure versus unexposed. What is the difference in incidence between the exposed and unexposed groups? That is essentially just asking, what is the attributable risk? So here's a practice question. You guys can practice this on your own. We'll go over it now. In a cohort study, the incidence of MI, or myocardial infarction, in patients with hypertension 8%, while in patients without hypertension, it is 3%. Which of the following best describes the attributable risk? The attributable risk, and then they want me to understand exactly what that means. You'll see that a lot of your biostats questions will be more so, what does this mean? More so than what is the percentage, what is the number, what is the value? So what exactly is this asking me? What is the attributable risk? So I know attributable risk is going to be the exposed minus the unexposed. Well, what is the disease first? The disease is myocardial infarction here. The exposure is if you have hypertension or if you do not have hypertension. So essentially the exposure is going to be my 8%, and I'm going to minus this from my 3%. So I'm going to get a total of 5% attributable risk. So this 5% here is the excess risk due to just the hypertension alone. Meaning, 5% of myocardial infarctions in hypertensive patients are attributable to the hypertension alone. That is what this 5% means. So hypothetically, what this means is that we could have prevented these myocardial infarctions if we eliminated the hypertension. So what answer choice best describes that? That will be 5% of MIs could have been prevented by treating hypertension. That is attributable risk. Moving forward, we have number needed to harm. Number needed to harm is simply just the number of patients needed to be exposed to a risk in order for one patient to be harmed, just like the name entails. Essentially, the higher the number, the safer the exposure. We want this value to be as high as possible. Now, number needed to harm is 1 over attributable risk. 1 divided by attributable risk. The 1 divided by the likelihood of getting the disease from just the exposure or just the risk itself. The definition makes sense if you understand the prior definitions. So to really understand this, let's look at this question. We have in a trial of 1,000 patients, 80 patients taking the drug developed agranulocytosis compared to 20 patients in the placebo group. Based on this information, how many patients would need to be treated with the drug before one additional case of agranulocytosis occurs due to the drug? This is how the question is typically formed. How many people do you need to get this drug before there's a bad outcome? So let's quickly put this together. I usually like to convert everything to percentages, but that's just me. You do not have to. But if I see 80 patients out of 1,000, that tells me it's 8%. If I see 20 patients out of 1,000, that tells me that this is 2%, right? 20 divided by 1,000 is 2%. So I first need to calculate the attributable risk. The risk that is the percentage that is attributed to just the risk alone. So that would be 8 minus 2. Remember, this is in percentage, is equal to 6% or 0.06. Always be sure to, when you're doing these values, to calculate into decimal points. Number needed to harm is 1 divided by attributable risk, or 1 over 0.06, which comes out to being roughly 17. So 17 people need to be exposed to the drug in order for there to be a poor outcome. And that is number needed to harm. We now have absolute risk reduction. This is known as the difference in risk attributable to an intervention compared to a control. This sounds very similar to attributable risk, right? That's because it is. The only difference here is that this is usually a positive exposure or a positive intervention. Like I said, not everything is always comparing negative, smoking to cancer. Sometimes we can expose people such as getting vaccines, which is typically believed to be a positive exposure to the lack of developing a disease. So what is absolute risk reduction? Well, we can draw out a little table here, right? We already remember A, B, C, D. Here's the disease, here's no disease, or here's the risk, I should say, sorry. So what exactly is it? Well, this is going to be very similar to attributable risk, but instead this is going to be your control minus your risk. It's the opposite, control minus the risk. Typically talking about a positive exposure. Okay, attributable risk is risk minus control, exposed minus unexposed. Absolute risk reduction is going to be your unexposed minus your exposed. Okay, it's the opposite. So let's do a quick question here. We have, if 2% of patients who receive a flu shot develop the flu, while 8% of unvaccinated patients develop the flu, what's the absolute risk reduction? So 2% of patients receive the exposure, okay? 8% of unvaccinated patients develop the flu. So these people did not receive the exposure. So remember, this is control, the people who did not receive the exposure, so that's going to be 8 first, 8%, minus the people who did, minus 2%. That comes out to 6%. Notice how I highlighted up here absolute risk reduction. To be honest, attributable risk and absolute risk reduction are essentially the exact same thing. The only difference between the two is what we're comparing. One is comparing some sort of risk factor, typically a negative thing. One is comparing some sort of intervention, typically a positive thing. exposed minus unexposed, or unexposed minus exposed. It does not matter. If I were to reverse this and I were to do 2 minus 8 and I were to get negative 6%, the absolute tells me that this should be an absolute value in which I would get the exact same number. That's a little cheat on test day when you forget your equations. Just note that you always want to use the absolute value of things. But always understanding this definition should help you. But if you were to mess up and you were to put it backwards, as long as you use the absolute value, you should always get the right result. Here are some other ways that they might ask this question on test day. Notice how it is all positive things, some sort of treatment, some sort of drug, and how it is associated with a decreased risk. That is a big takeaway point with absolute risk reduction. A positive intervention is being given. Take time, pause the video, do this practice question. We have a randomized control trial evaluates a new cholesterol lowering medication in patients at high risk of cardiovascular events. In the control group, we have 120 of 1,200 patients experience a cardiovascular event over 5 years. In the treatment group, or the exposed group, we have 72 out of 1,200 patients experience a cardiovascular event at the same time period. What is the absolute risk reduction associated with the new medication? Well, the absolute risk reduction, I already know, is just going to be the unexposed, aka the control group, minus the exposed, or whoever got the risk factor, or the exposure, or the intervention. Notice how it's a positive intervention. It's a treatment group. It's a good outcome. Something's going to happen probably positively. So I'm just going to quickly convert this to decimal points. So 120 divided by 1,200 is 0.1, or 10%, minus 72 over 1,200 is going to be 0.06, or 6%. This comes out to 0.04, or 4%. The absolute risk reduction is going to be 4%. Notice, if you were to reverse these, as long as if you were to reverse them, you would get minus 0.04. Take the absolute value of that, and you would get 4%. You would get the exact same value. Again, I still emphasize to understand exactly what's going on. Understanding the definition will help with the equations. Number needed to treat is going to be one of our last talking points. These are the number of patients who need to be treated for one patient to benefit. The lower the number, the better the treatment. Why did I put it here? Well, just like with number needed to harm, it's associated with absolute risk reduction, just like how number needed to harm is associated with attributable risk. Remember, those attributable risk and absolute risk reductions are very similar to one another. But when you think about them as equation basis, they are the exact opposite. Unexposed minus exposed versus exposed minus unexposed. So number needed to treat is 1 over absolute risk reduction. The best way to learn this is with a practice question. So we have in a study on statins, we have 4% of patients on placebo had a heart attack. 2% of patients on statins had a heart attack. How many patients need to be treated with statins to prevent one additional heart attack? How many patients do we need to treat in order there to be one outcome? I know they're asking me for number needed to treat. So I first need to calculate my absolute risk reduction. Remember, my absolute risk reduction is my unexposed minus my exposed. In this case, the placebo, or the group, the control group. So it's 4% minus 2%, the people who have had the exposure. Even if you were to flip it, you would still get the same exact outcome if you always do the absolute value of things. 2%. Or, remember, always convert this to decimal points, 0.02. 1 divided by 0.02 is 50. I need to treat 50 people in order to have a positive outcome. That covers our primary objective of observational studies, going over the calculations with case control versus cohort and how we interpret these. For completeness' sake, I've included the other observational studies, such as twin concordance studies, which are observational studies that compare the frequency to which monozygotic and dizygotic twins develop the same disease. And adoption studies, which are observational studies that compare siblings raised by biological versus adoptive parents. These studies are not very hard to decipher on exam day, but what they are used for is very, very high yield and is typically the question. This is useful for determining nature versus nurture. Nature versus nurture, which is something that you probably have learned in undergrad. What is the likelihood of developing certain characteristics in certain diseases based off of exposures, such as nature, versus nurturing or being raised in different environments or by different people? That's the big takeaway point from twin and adoption studies. The last one we'll talk about is something known as ecological studies. Up until this point, we've primarily been talking about individual results. How do I can relate this to an individual? Ecological studies are interesting in the fact that they are a type of observational study where the data is collected and analyzed at the group or population level. I can relate this to an entire population rather than just one individual. Where you'll be asked with this on test day are the key features. Why is this important? Well, the key features of this is obviously it relates to a giant population more so than just one individual. It often is used to compare diseases with different exposures across different regions, whether those regions be in the same country or different parts of the world, or different time periods, such as the 1980s versus the 1920s. This is also quick, cheap, and useful for hypothesis generation, not just causation. Now, the limitations are pretty self-explanatory. If I'm going to be using this for population-based, I cannot interpret these for individuals. That is the limitation. This is the key takeaway point from this slide. And that concludes this lecture on observational studies.